Metabolic acidosis is a serious condition signaling systemic dysfunction, commonly seen in critical care. Understanding its classification helps guide effective treatment strategies. Metabolic acidosis is a blood pH less than 7.35 caused by reduced bicarbonate. Key mechanisms are excess hydrogen ion accumulation and loss of bicarbonate via gastrointestinal or renal pathways. The condition disrupts cellular processes, causing issues like impaired enzyme activity and decreased oxygen delivery to tissues. Sometimes, despite being in metabolic acidosis, patients may have normal pH. It is called compensated metabolic acidosis. In this condition, there is low bicarbonate compensated by respiratory alkalosis, maintaining near normal pH. Common examples are chronic renal failure and resolving diabetic ketoacidosis. While compensation stabilizes pH temporarily, untreated causes can lead to decompensation, resulting in critical illness. The severity of acidosis correlates with clinical urgency. Severe acidosis often requires ICU-level interventions, such as hemodynamic support or dialysis. Severity of metabolic acidosis is dependent on pH. In mild acidosis, pH is between 7.30 and 7.35. Bicarbonate level is between 18 and 22 milliequivalents per liter. In moderate acidosis, pH is between 7.20 and 7.29. Bicarbonate level is from 10 to 17 milliequivalents per liter. In severe acidosis, pH less than 7.20, bicarbonate level less than 10 milliequivalents per liter. Key symptoms are fatigue, nausea, abdominal pain. In moderate acidosis, small respirations, and in severe cases, confusion, arrhythmias, hypotension, and hyperkalemia-related symptoms. Symptoms vary by underlying cause, with conditions like DKA producing distinct signs like fruity breath and small breathing. Causes of metabolic acidosis can be better understood based on anion gap. High anion gap metabolic acidosis, which is accumulation of unmeasured acids like ketones, lactate methanol, and methanol poisoning. Normal anion gap metabolic acidosis, which is caused by loss of bicarbonate or reduced hydrogen ion excretion, like in diarrhea or renal tubular acidosis. The anion gap is critical in distinguishing high anion gap acidosis from normal anion gap acidosis. We will look at three types of renal tubular acidosis today. Type 1 or distal, which is caused by defective hydrogen ion secretion. Type 2 or proximal, which is caused by impaired bicarbonate reabsorption. And type 4 or hyperkalemic, caused by aldosterone resistance or deficiency. Each RTA subtype has unique clinical and laboratory findings, requiring tailored treatments like potassium-sparing agents or alkali therapy. To diagnose, we need arterial blood gases. If pH is less than 7.35 and bicarbonate is low, it shows us decompensated metabolic acidosis. Serum anion gap needs to be calculated then to differentiate high anion gap metabolic acidosis from normal anion gap metabolic acidosis. Delta ratio calculation is next step to detect mixed metabolic acidosis. To differentiate between pure high anion gap metabolic acidosis from coexisting normal anion gap acidosis, or metabolic alkalosis, and urinary anion gap to identify renal versus gastrointestinal bicarbonate loss. This systematic diagnostic strategy ensures coexisting conditions like metabolic alkalosis or chronic respiratory acidosis are not overlooked. Special tests for underlying causes can be performed after the diagnosis is ensured. For examples, ketones for DKA, serum lactate for lactic acidosis, or osmolol gap for toxin ingestion. Targeted investigations uncover specific triggers, such as toxic alcohols or ischemia, enabling rapid, precise treatment. General principles of treatment are to first correct underlying causes, like sepsis or toxins, to optimize oxygen delivery and perfusion, and of course to address electrolyte imbalances. Acidosis treatment prioritizes stabilizing the patient's hemodynamic status while addressing reversible causes. To manage specific cases like diabetic ketoacidosis, treatment needs to be tailored. In DKA management, we need to start fluids as soon as possible, generally normal saline and then adding dextrose when glucose 200 mg per deciliter. Continuous insulin infusion needs to be started and titrated to reduce and maintain steady glucose reduction. Aggressive potassium replacement is essential if 3.3 milliequivalents per liter before starting insulin. Rapid correction of DKA can lead to complications like cerebral edema, necessitating close monitoring and gradual interventions. Complications and risks are volume overload, hypokalemia, and rebound metabolic alkalosis. Gradual correction of acidosis and careful fluid management is needed for prevention of complications. Proactive management of complications ensures a smoother recovery and minimizes long-term morbidity. Sodium bicarbonate therapy is controversial and reserved for severe cases due to risks of rebound alkalosis and hypernatremia, but is vital and essential in severe cases. Indications are severe acidosis when pH is less than 7.1, hyperkalemia with high cardiac risk. Start with 1 to 2 milliequivalents per kilogram IV and then reassess frequently. Hemodialysis is very important and can be life-saving in very severe cases. Generally used for refractory acidosis, renal failure, or toxin removal. Key parameters to monitor during treatment is arterial blood gases for pH, bicarbonate, and partial carbon dioxide, electrolytes like potassium and sodium. Frequent monitoring helps adjust treatments dynamically, reducing the risk of treatment-associated complications. Thank you for your attention.